Now, you can tell from the title, if you're seeing my title slide, that it's already controversial, because we're going to talk about liver transplant for AUD, alcohol use disorder. That's the term I'm going to use. And I'm going to try and present science, the rationale for doing this, the outcomes, the facts. And there is some stigma associated with alcohol use that has prevented some liver transplants for alcohol. And I'm going to get into that a little bit, and maybe that's where the controversy comes from. Okay. So let me start with this. Liver transplant, I know you know this, is wildly successful. Liver transplant takes very, very sick people that are mathematically certain to die in the near future, and gives them long-term survival in normal life. The most common indication for liver transplant is alcohol use these days. It used to be hepatitis C. There are other conditions. Some people on this phone will know more about these than I do. They've lived with them. But the current most common indication for liver transplant is alcohol use. And as I'm saying, it's very, very successful in that situation as well. Liver transplants that are performed for alcohol use are very successful, short and long term. And they're nothing to talk about. They go great. So there is some stuff to talk about. And what I'll talk about is a little bit focusing on this notion that there are rules. And the rules I'm referencing are a 6-month rule. You have to quit drinking for 6 months to sort of get a liver transplant. And I'm going to show you some work that we've done at Hopkins that calls that rule into question and suggests that a pass-fail test for liver transplant candidacy that is based on 6 months waiting period is not necessarily a good idea. That's where I'm going to come at it this morning, but we can talk about other stuff as well. Okay. All right. Again, I can't really see all you guys. So if you got something to say, scream it out or put it in the chat. All right. I'm going to try and advance here. You guys tell me how I'm doing. Am I advancing okay with the case? You guys see my case? All right. I'm going to tell you about it. Yeah.
This is Nina Martinez, your kidney donor that's living with HIV, the first living kidney donor in the U.S.
Yep.
Hello. I just wanted to see if after you go through your slides, I do have a personal experience with losing someone to liver transplant because of the unfair 6-month sobriety rule. And I would like to share with the group if no one is opposed, and we could talk through that.
Okay by me.
Sounds good. Thank you.
All right, I'm going to present a real life case here, and you guys can tell me what you think. So there was a 61-year-old woman who was a school teacher. She was from Maine, and she was admitted up to her local medical center in Maine with SAH, severe alcoholic hepatitis. That means you're critically ill today from drinking today. She was indeed a heavy alcohol user. That was not in dispute. It had not interfered with her work previously as a school teacher. She had had no DUIs, for example, or any other negative consequences. She was happily married. At that local center in Maine, they gave her steroids, which is the only medical treatment for alcoholic hepatitis. And it didn't improve her, and she was certain to die. They transferred her to hospice to die. Her local PCP was a fierce advocate for his patients, had found some stuff we'd published on the topic, sent her all the way down to Hopkins, transferred her. And we met her down here and worked her up. Her husband was at the bedside, advocating for her. And the question was, should we transplant her or not? True story. Maybe, I don't know, 8 years ago. And if I took a vote of this group, I don't know how we do. Some people might say, yeah, some people, yes, no. In general, you're not, That doesn't meet the rules. That's you're not 6 months sober. There's 157 liver transplant centers in the United States. If you took a poll of them, the verdict would probably be 157 to 0, no go. All right, let me keep telling you the story here. So this is alcoholic hepatitis. I want to make a distinction there. This isn't alcoholic cirrhosis. Is I've been drinking for a long time. I've got end-stage organ failure, but maybe I've stopped. Maybe I stopped 6 months ago. Maybe I stopped 3 years ago, but I have the liver damage to show for it, and I still need a liver transplant. This is a little different. This is I've been drinking up until recently, and I have an acute situation. I'm acutely sick from my drinking. And there are ways to mathematically measure, just like the MELD score measures your likelihood of dying without a liver transplant. There are scoring systems, kind of similar, to measure your likelihood of dying from alcoholic hepatitis. And they predict very, very high short-term mortality. This, school teacher is going to die for sure. They sent her to hospice. And again, most transplant centers, all transplant centers in the United States have sort of had this agreement, this rule. It's not a law. It's a rule that you have to be 6 months sober, 6-month waiting period. Now, this is funny. Michelle remarked on Professor Starzl in the background there. Dr. Starzl was an advocate of transplanting for alcohol. He thought it was a good indication for liver transplant. And he sort of said tongue in cheek, liver transplant is the cure for alcoholism. And that's a funny statement. But he believed that for a lot of people, their moment of insight or epiphany or understanding where they realize I got to change my life. For some people, that's a DUI. For some people, their significant other leaves them. They lose their job. For others, it's a liver transplant. And that is the wake-up call that makes them not drink anymore. Kind of interesting. Again, controversial. So where's the 6-month rule, 6-month kind of rule of thumb come from? The idea behind it maybe is kind of obvious. The idea is you're going to pick people who have sort of demonstrated that they can and will not drink after liver transplant. The notion is also if you don't drink for 6 months, you might get a little bit better and not need a liver transplant or not need one soon. But that 6 months, where does that come from? And the answer is it doesn't come from good hard data. It's not that 6 months is something magical, and we know that from the data. If you're 5 months sober, you're in danger, but if you're in 7 months sober, you'll never drink again. It's not the case. Length of time of sobriety before transplant probably is predictive in that more is probably better for patients not having a problem afterwards, but there's nothing magical about a pivot point of 6 months. There's no data that really supports that. You with me so far? But that's nevertheless, that's the rule. Okay, let me show you something interesting. This was the rule, okay? And really no break in the rule. In 2011, all right, there was this New England Journal paper that was published that was very controversial and shocking as well. And what they did, it was a paper from France. And in France, they had 6 or 7 liver transplant centers that decided to transplant patients like that school teacher who did not have the 6 months. And this is a graph that showed the results of what they did. They ended up transplanting 26 patients with acute severe alcoholic hepatitis, and they got really good results. They looked at a control group of equally sick patients that they didn't transplant. And that's the bottom line. The survival was very low. 80% of them died, as would be expected. The higher line you're hopefully seeing is the survival of the transplant group. 80% of them lived. And that was exciting. That we don't want to be withholding a life-saving therapy for people that can benefit from it. Maybe even more interesting is you can see there I wrote down 12% recidivism. Of these people that had not had the all magical 6-month waiting period, because none of them did, only 12% of them went back to drinking after transplant. Now, I don't know if you think that's too high or too low or the right number or whatever, but For people that had had no prep on the front end, whatever, 88% of them didn't go back to drinking. That's sort of Tom Starzl's that the cure for alcoholism is liver transplant. I'm going to tell you one other curveball stat, which is if you look at the folks that have had the 6-month waiting period that we've all agreed upon is so important, and I ask the same question, what percentage of them go back to any drinking at all? The answer is 20%. So that's maybe the denominator we have to compare to when we look at this group that doesn't have the 6 months. All right. So you might think that everything changed after that study. Nothing changed. The transplant practices in Europe changed, and they started transplanting not as much concerned about the 6-month waiting rule. In the United States, it didn't change. This is a paper from Mount Sinai in New York, in which they repeated the French study. This is only 9 patients, and they showed the same thing. Without transplant, the patients did very poorly. With transplant, they did very well, and they had 11% relapse, one person. So it was, but that was it. It was like a little cricket chirp, the only people that did it in the United States. All right, so in 2012, our liver team was cranking up at Johns Hopkins, and we decided to initiate an identical pilot study. We agreed that we would use a multidisciplinary team to look very carefully at patients that came to us that needed a transplant. They had to be critically ill. If you could wait and not have a transplant, we waited. But if you came to us and we all agreed you were going to die without one, we looked you over really carefully and considered bending the 6-month rule and doing the liver transplant anyway. Okay, that started in 2012. All right, and here's 2012. If you're seeing my slides, we did a couple. We started dipping our toe in the pool like the French people did, and we did a couple, and then the program grew, and then it grew and it grew and it grew. And I'll show you the results of those efforts up to very recently. You ready? We're almost done here. So this is a complicated slide, but it's kind of interesting. We have now performed at Johns Hopkins 122 liver transplants over the last 10 years for folks that did not have the 6-month waiting period. By far the largest series in the world. So recall that New England Journal paper with 26 patients, and that was worth bragging about internationally. We've done 122. And that other study from New York did 9. Okay, so this is a lot of folks. Now, this is an interesting slide. 2012, 2013 along the line here. Here's where we started. The blue dots are these early liver transplants for alcohol without 6 months waiting. The red dots are standard liver transplants. You waited 6 months and got your transplant for alcoholic cirrhosis. And you can see just a couple blue dots in 2012, now more blue dots. And there you can see these numbers were early liver transplants were in the single digits, then in the teens. Now we're doing 20, 25 a year, 2 a month. Couple other interesting things. Look down here at this couple interesting things here. This was the start of a government grant we got to look at this more carefully from the NIH, and our numbers really took off once we had governmental funding to support these efforts. Then I'll show you another interesting thing. 2020, we all know what happened in 2020 in March. COVID happened. COVID hit. And we didn't know what was going to happen. We thought there was going to be, a zombie apocalypse, not enough masks, not enough ventilators. You maybe don't even remember this 2 years ago. But we had to stop doing we shut down Johns Hopkins. We didn't do elective surgeries. We didn't do any liver transplants unless you were about to die. And standard liver transplants, we put off if we could. But the blue dots kept coming because there are people that roll into Hopkins deathly ill and they can't wait. And we kept going. And if anything, if you look at COVID, let's talk about COVID. COVID's terrible. COVID has affected everybody on the Zoom call in some way. Some folks lost their lives. Some folks lost their jobs. Some folks missed their graduation or their wedding or their trip to Europe, whatever. But it affected everybody. And if you look statistically, drinking went up, alcohol sales went up, DUIs went up, dysfunctional drinking during COVID, during those very, very socially difficult, isolating, depressing, demoralizing 2 years, alcohol use went way up. And our emergency liver transplants for alcohol went up too. All right, let's keep trucking. We published these results a year ago, and this is a summary of our specific results with this program, comparing these early liver transplants versus the standard liver transplants for the first 88. So I told you we've done 122 up to like yesterday. Through November 2020, the first 10 years, or the first 8 years, if you will, of this pilot program, we've done 88. And we compared those 88 early transplants compared to these standard liver transplants where you had 6 months. Let me walk you through these slides and then we can quit and we can talk. Okay. Here's the results from Johns Hopkins. These slides show patient survival over the first 3 years after transplant, or graft survival. So if the patient survived but the graft didn't, that means you had to get retransplanted. They're very similar numbers because retransplant's not that common. And the yellow line is these 88 early patients that are sort of interesting and controversial, the pilot program that I'm reporting on. The blue patients are the standard patients. Their results, as you can see, are identical. There was no difference in 1 year patient survival in the folks that had the 6 months versus didn't. It was 92 versus 94 and 94 versus 96% 1 year survival. The results were incredibly good, and they were identical for both groups. 6 months didn't seem to be an important predictor. Okay, let's keep trucking here. We're almost there. This is maybe the most interesting. This is return to drinking. Okay, in both groups. The first panel here, A, is any drinking, any one drink. The second panel is what we call return to hazardous drinking. And there's a specific medical definition of that. It's 4 drinks a day, it's binging, there's very specific NIH definitions of hazardous drinking. And, to give you the spoiler, the return to drinking, either any drinking or hazardous drinking, was statistically identical between the two groups. It wasn't that if you were in the early group and hadn't had the 6 months, you had a much higher relapse rate. Now, interestingly, our return to drinking, is as if you can see here, is 80% all comers, any drinking. The return to hazardous drinking is less than that because there's folks that go back, have a slip up. They have one drink, they feel terrible, and they don't drink anymore. And that's the 20% all comers, but then there's 10% that return to hazardous drinking. So that now you're getting a feel for it. Let's say we've done 100 patients. Let's say 94, whatever the number is, 94% are alive and well. Let's say 20% of that 100 return to any drinking. And let's say 10%, half that 20%, return to harmful drinking. And those numbers are identical, whether it was 6 months waiting or not. All right, you get the idea. This is each one of these bars is an individual patient, when they relapsed and what happened to them. And it's sort of a complicated slide, but what I'll show you here is this is how long we followed them out. Some of them are years out from transplant. And the last box in this chart is either green or clear. And if it's green, they're still drinking. And if it's clear, they've returned to sobriety. So it's not really a linear thing. Oh, you had a relapse, you're a drinker. No. Some people have it returned to drinking and then return to sobriety. And at last check, of the folks that had had any relapse, half them had returned to sobriety. So of the whole cohort of folks we did, of these 122 patients that we did without 6 months, 90% of them are sober at last follow-up, which is pretty high. And it's certainly the same as the folks that did have the 6 months. All right, we're almost there, guys. So this patient I presented to you, this real life school teacher from Maine, we did transplant her. She did great. They all do great. She left the hospital on post-op day 12. She never went back to drinking. She retired. You can go meet her. She's working for her church, alive and well. So I don't know. We feel good about it. We feel comfortable with it. We're bending the rules. I don't know, breaking the rules. I don't think the rules make sense. And I got 100 people that walk the earth alive and well, because of it. All right, I got two more slides and 3 more slides. So this is the government grant I referenced. We don't want to do this casually. We want to do this, with adults carefully. And so as scientists, we've described a rigorous way to approach the selection of these patients and how they're going to be treated. How are we going to just do the transplant and be done with them and see them in clinic and say, oh, how it's going? Or are we going to help them with preventing a return to drinking? And there are, proven strategies to help people avoid a return to drinking in other scenarios, not transplant. And we're using those in this transplant scenario, which is novel. And the government, the NIH is very, very, very interested in this novel strategy and is supporting us to pull it off and to take good care of these folks and to follow them and to report on it with the hopes that other so I told you in Europe, everybody's doing it. In the US, nobody's doing it. We're doing it. Nobody else is doing it. And that's controversial too. If you live in Kansas and you're this school teacher, you die. If you happen to live close enough to get to Baltimore, and Maine's pretty far, but if you live close and you can get transferred, you live. That's not fair. And that's not right. And that's not the way the government or UNOS wants transplant to be. Transplant is supposed to be equitable and fair. And it shouldn't matter if you're from LA or Appalachia or Florida. Everybody should have the same day in court. And currently, this is probably a really good idea, but until others use it too, it's disparate access. And that's suboptimal. And so the NIH wants us to help expand and export to other liver transplant centers so they can do it too. So it's fair again. All right. Life-saving therapy for patients with no other option. We've confirmed that. The French guys showed that. Same deal. Outcomes are similar to patients. The ongoing sobriety, as I mentioned, is somewhere 90-95%. We are trying, of course, to figure out who these people are in advance so we can, transplant the right folks that are going to do well. That's hard to be perfect at. I mentioned this government grant that the NIH is helping us with. And I think it just ultimately calls into question the value of the 6-month waiting period, which back to my first slide was more based on stigma. You don't deserve a liver transplant. And that's not how that's not how medical care typically works. We don't look at a guy with lung cancer and say, oh, you don't deserve a lung cancer resection because you're a smoker and you did this to yourself. And, we're not here to help you. That's not how we do it. So we're trying to study it very carefully. This is the team of folks. It certainly wasn't me. It's a whole big army of folks at Johns Hopkins. Some of these people you may know, and these are our wonderful patients, which is the real reason why we do it. That's it. I'm done. I'm done talking. I'm done. I am happy for you guys to talk amongst yourselves, to give your own stories, to ask me questions. Tell me you love it. Tell me you hate it, whatever you want to do.
Dr. Cameron, you have 2 people who have their hand raised. Mark from Annapolis and Joanna. Maybe one of them can ask you their question.
Go ahead, Joanna.
Let's roll.
Go ahead, Joanna.
Thank you for having me, and thank you for putting this together. There was a similar study that was done at the University of Toronto General Hospital, and the study came out last year in the Journal of Gastroenterology, and they found similar results. Meanwhile, the results were not statistically significant, but the great thing about it was that patients did not return to drinking. So my question is sort of twofold. One, their study and their methods focus on post-transplant care, focusing on mental health, therapy, rehab, if applicable, those kind of things. And I was wondering if your center focuses on that as well. And second part of my question is, what do you believe is the hesitation for other centers to, adopt this rule or, break the rule of the 6 months sobriety?
Thank you. Very good questions. All right. First question is what do we do for treatment on the back end? And the answer is, when we were getting serious about
get
this.
him.
Can you hear me okay? Yeah.
Yes.
When we decided to embark on this, I went around to the substance use counselors, the transplant psychologists, the substance use specialists, and said, will you help me? Because I'm a transplant surgeon and I'm good at the operation, and the bilirubin is one, and nobody's rejecting. We're doing great, but I am not an alcohol use counselor. And it was not well done. I would see him in clinic. You doing okay? Yeah. Okay. See you next. See you. You're not drinking, are you? No. Very unsophisticated. And so we adopted with our colleagues best practices. There are best practices for preventing relapse. And they are things like behavioral therapy, individually administered sessions, group sessions, participation in typical groups like AA or individual counseling. There is pharmacotherapy. Okay, so there's literally medicines that have been shown to reduce cravings for alcohol. Antabuse, Flagyl, Camperstate, naltrexone. So we embarked on a scientific effort to use best practices to help people with relapse. And that's a huge part of what we do. And that's a huge part of what the government is into. Okay, that's number one. I hope I answered the question. Number two is, why don't other centers do this? And I got a couple answers to that. And number one, it's kind of hard. So the patients are very sick. And there is outcomes measurements in the United States where you have to live up to certain standards, or CMS or UNOS will have regulatory oversight. These are very, very sick, high acuity patients. So they're tough ones. Not everybody's up for it. Number two, people like rules. People like, I follow the rules. This is by the rules. I am comfortable with this transplanting this patient because I'm within the rules. So I don't know if you guys are familiar with transplant for liver cancer, HCC. There's very good rules for that called the Milan criteria. If you have one cancer and it's less than 5 centimeters, you're a winner. If it's bigger than that, you're not a winner. People love that because it's a safety blanket. And I know if I transplant you within the rules, I'm a good guy and I'm going to get those good results, which the government wants to see. And I'm being fair because everybody wants to be fair. They want to seem fair. This is dangerous territory for people because it seems unfair. And it seems like they're bending the rules and they're not sure what's going to happen. So it's our job at Hopkins to create a new set of rules. Don't get me wrong. I don't want there to be no rules. I don't want anybody gets a transplant. Nobody's paying any attention. I don't want that. That's not fair to the people that donate. I am merely suggesting that we have rules that make sense. I'm trying to tell you the 6-month rule as a pass-fail test doesn't work. It doesn't make any sense. It's not effective. It's not a good rule. I want different rules. There are things that predict whether you're going to do well with your transplant after drinking. There are. And I want to use them. They are things like, how much insight do you have? How much of a supportive social network do you have? Blah, blah, blah. There are other valid predictive rules. I merely submit that we use the rules that make sense and move away from the brain dead easy rule of 6-month pass fail. That was easy. I played by the rules. That doesn't make sense to me because it doesn't predict. That's why other centers are slow on the draw. But I think that we could have a multi-center, multi-institutional trial where we start disseminating this so that it's less geographically unfair. I hope that's a good answer. Next question.
Thank
Okay,
you.
Mark is next. Mark Morose.
Thanks, Michelle. Mark, alcoholic, and I'm going to introduce myself that way because I loved your presentation. It was very concise. Showed the progression from when I've had my transplant in 2013 to where you are today, which is a huge difference. But my doctor prescribed me a medication for my alcohol use, and that was the program of Alcoholics Anonymous. And you mentioned it once after your presentation, but that prescription told me to take this prescription through my ears and listen to what those people had to say. And you're right, it's a support group. But I think that the stress of AA, it turned me around to the fact that in my thinking and my alcohol use, that I would not go back. And one of the main things that drives me, I go to a meeting twice a day, 7 days a week for 9 years, for 10 years. I'll be 10 years sober May 20th next week, 10 years. And what I've learned in this program is the thinking that, that'll keep me from drinking after alcohol use. And one of the things that drives me in what I've learned in the program of Alcoholics Anonymous is that it would be morally terrible for me to go back out drinking on somebody else that took the time and made that decision to donate. Either was that person, or I've learned through the years that it might have been the family that made that decision to donate that organ. So I'm going to draw a little bit of a moral issue into it, because that keeps me driving. That keeps me from going back out and having at it. Because when you drink the way I drank and then get a transplant, when you go back out, you go right back where you left off. You start exactly where you left off, which is almost death. So again, I enjoyed your presentation. Thanks, Marty and Marty and Michelle, for putting this thing on. I really was intrigued by the title, and that's my story, and I'm sticking to it. Thanks,
Mark. That is a wonderful story. Congratulations,
Dr. Hudson prescribed me this program.
I mean, I love every part of your story. So I love that the success you've had. You bring it into play AA. Which is super valuable and super important for a lot of our patients. And you've had this really good success, and I'm going to follow your lead there. So you're invoking this moral responsibility that you have to not drink, now that you've been given the second chance in somebody else's liver. Got it. Love it. That's so intuitive and so clear, and it has powered you to do well. Let me talk about that for a second. What's the flip side of that? Okay, so stick with me here. We do this innovative program, which I'm bragging about. We're very proud of, and we've saved 100 people's lives, and it's very important. Pause for a second. Think about the people that did not do well, okay, because they went back to drinking. Okay, so this is heavy. All right, people come to us sick. We do the best we can. We decide, we agree out loud, transparently, to bend the rules. Somebody dies so that they can live. Somebody else dies that doesn't get the organ. We did that. I did that. Some kid with biliary atresia didn't get the transplant. This guy did. That person goes back to drinking. How powerful is this disease and addiction? How dense is this disease that we would bend the rules, you would get a second chance, and you still would go back to drinking? Wow. I mean, the government is fascinated. The government says, holy smokes, those are the people I want to study. I want to study these people who have such a severe form of the disease that even after they get transplanted, they can't help themselves, and you can't help them. Okay, so stick with me here. Some of those people die, go back to drinking, and die after their transplant. And I want to tell you this, it's maybe a statement of the obvious. It's catastrophic. It's to the person that died, to their family, to the medical team, to the nurses that took care of them. It weighs so heavily on the team that many of my teammates will say, we shouldn't be doing this. This is messed up. And I'll go you one further. What I really worry about is the donors, the donor families. Okay. So we can only do this good work because folks donate. They donate their loved ones' organs. And when they do that, they trust us. They say, you take good care of this organ. What if my daughter died and I donated her liver and the surgeon dropped it and it didn't get used? I would burn the hospital down. You trust the surgeons to be good, the team, society to be good shepherds. And I'm convinced I'm being a good shepherd with these organs, and I've shown you the results, and I'm trying to be very careful, and I'm trying to prove to you that I'm doing a good job. And I'm doing that by comparing it to other uses of these limited resources. But what I worry about is when the public hears about a catastrophic failure, few of them, but I'm describing them, they exist, and they say, well, wait, I knew you were going to do that. That's just what I didn't want you to do. If we went down to the DMV today and we sat there and 100 people got their license, 30 would check yes to donation and 60 or 70 would check no. And if I got the 70 people in a room and I say, why did you say no to organ donation? They would tell me one of 4 very typical things. The first thing they would tell me is that I'm not going to check yes on that box, because if I check yes and it's on the back of my license, when I come into the hospital sick, doctors won't work hard to save my lives because they want my organs. And that is scary. That is indicative of terrible mistrust in our society, that folks think that I would kill you for your organs. But our society is a mess right now, and nobody agrees on anything. And I don't trust the government either. Tell you the truth. The second thing they would tell you is, I'm not going to donate because I know what you do with those organs. You give them to rich people. You give them to white people. You give them to drug abusers. You give them to alcoholics. And we say, we got a system. We're fair. We're transparent. Trust me. And they say, okay, I trust you. You can have my daughter's organ. I trust you. And then they find out that that's just what we did. We gave it to somebody who didn't play by the rules, and they went back to drinking. See what I'm saying? This is heavy. This is heavy. And it's your story keeps me powered, keeps me going. And I've done 122, and I got 94% of people that are keeping me going. And I've got some stragglers that are keeping me up at night. And I worry about it. And we got to get it right, because it's a public trust. And, it's tough on the team. And if I'm going to tell all the other transplant centers in the United States, you got to be doing this too, I better have my story straight. You know what I'm saying? So it's very, very challenging. And that's why we're taking it seriously. And that's a long answer to your story.
I love that counterbalance, doctor. Thank you. Because it's true.
Yeah,
it's definitely true, but it's a hot topic in my head. So.
But what are we doing here? So we do, somebody smokes cigarettes. They have a lung cancer. We take it out. Again, it's not, you don't deserve it. Somebody has a recurrence after their surgery. Does that mean we shouldn't do any more surgeries for lung cancer? It ain't perfect. Nothing we do in this hospital is perfect. This is what we're trying to figure it out. And we're kind of working hard on it. You get the picture.
Thank you, Dr. Cameron. Nina Martinez has been very patient. She has a question for you.
Please.
Hi, Dr. Cameron. Do you remember me?
I do.
It's been 3 years since I donated a kidney as the first person living with HIV in the United States to another person living with HIV. A lot of the things that you said during your presentation, I'm glad that you said them, because I am a person living in Georgia who is on this Maryland call, but I am a person from Georgia who had to travel to Maryland to donate, because, as you know, only certain centers do the HIV to HIV transplants, just as it's apparently just you guys that do the liver transplant for people with less than 6 months of sobriety. So 6 months after I donated at Hopkins, a friend who lives in Baltimore, his brother lived here in Atlanta, and his brother was admitted to a local transplant center and was denied a liver transplant because he only had 5 months of sobriety. Now, mind you, I am still very new to the transplant space, and I entered it when I donated, since I donated as a non-directed donor, and my original intended recipient died 2.5 months before I was approved at Hopkins. I didn't have the kind of connection to community for people in need of transplants, so all of this was still very new to me. His local transplant center had denied him. I fought to get him a second opinion at a more progressive, some centers are more aggressive at pursuing every transplant. The second opinion did deny him as well, and he died a week after I met him, but he wasn't conscious. And I think it really speaks to, it was the same with the HIV to HIV transplants. It's the same with HIV care as it is with transplant care. You have to know who to know in order to know where to go. And that is certainly unfair. This past January, I did write a letter to CMS, and I talked about both the suboptimal intake of HIV to HIV transplants in this country, because yes, while it's legal, it's still not being done for the same reason that people don't want to transplant folks with alcohol use disorder, because of stigma. And I think that this pernicious misconception of a shortage of organ supplies, when we know that, you know, people don't recover all the organs from deceased donors who have registered first person legally binding authorizations, like, that's why people like me have to donate to expand the donor pool, is because we're not transplanting every organ from every eligible donor that we could in the US. And I just want to thank you for saying all the things that you've said, because they do reflect the reality that I have had, that my friend has had. I'm the adult daughter of an alcoholic myself, so I wanted to attend this discussion because I wanted to know the information I didn't know in September of 2019, that these transplants do exist. And I wondered, from a recruitment standpoint, what is Hopkins doing to get the word out? Or is it, as you said, that you have to live near Baltimore or the Northeast coast in order to know that these transplants are being done?
Yeah, sure. Thanks for all those comments. So I'm with you. I don't like unfairness. I don't like geographic disparity. You know, it shouldn't be that if you have leukemia, it depends, your treatment is based on where you live in the country. Nobody wants any of that. We don't want that for transplant. What is Hopkins doing? Well, first of all, I don't want to sound like a used car salesman, but we try and accept everybody. I mean, if we get a call, we try and say yes. If you're from Michigan, we get calls from all over, because we do publish this stuff. And we're not entirely, but we're a little bit the only game in town. And so people call us and say, we're not going to do this person. They're going to die. Do you want them? And we say, oh, send them. It's not great, because these people that we're talking about are critically ill. They're intubated in the medical intensive care unit on dialysis, and it's hard to fly them across the country. And that's not going to be the way to do it. The better way to do it would be to, export this program so that it gets done everywhere. So you can have it done in Georgia, or you can have it done in Michigan, or it can be local. And then we won't have to do everybody, because right now we do everybody on the East Coast, and that's why our numbers are so big. So we're trying to publish. I go and give talks, and then I like this one, and people listen, and then they decide it's okay or not okay. And other transplant centers call us. We're going to start doing this. Can we have your policies? Can we have your protocols? Can we call you if there's a problem? We have a tough patient. Should we do them or not? We need the government and UNOS to get involved. The tricky thing is that there doesn't need to be a rule change. Are you with me here? So it's not like, oh, we got to petition UNOS to change the rule and then everybody will do it. There is no rule against this. There's no rule. There's no law, if you will. There's no policy that you have to wait 6 months. This is a rule of thumb that is adapted by the centers themselves. UNOS says you can do whatever you want. In fact, if you go back to the UNOS meeting in which they considered policy on this, they proactively decided not to specify 6 months as a rule, because they thought it was legally indefensible and they thought they would get sued. So they said every
legally
case,
indefensible under the Americans with Disabilities Act, correct?
So, said case by case, let the centers deal with it. The centers then all said, it's a tough one. Why don't we just all agree on 6 months? And everybody said, oh yeah, that's easy. That's good. Let's do that. And so any center could change tomorrow and transplant whoever they want. And we just said in 2012, wow, there's this great paper. Looks like we could give it a try. And that's the next step, is other centers deciding that they too could do it. It does not require a rule change. So that, if there were a rule change, then they'd all probably say, oh, well, now I'm playing by the rules, I can do it. But because it requires them to sort of take the initiative, they've been slow to do it. Any other questions? There's some stuff in the chat
Well, we have Pat has her hand raised.
Go,
Pat's on
go.
her phone.
hit me.
Pat, you're up.
I have a quick question. I was transplanted under the 4 months, so I had 3 hospitals that didn't agree with me, and I had a hospital up the road from you guys, at Temple, that did it. And I was wondering, are you guys going to be working with Temple? Because I know Temple is going forward now, also doing the alcohol abuse. Are you guys going to be working with a lot of the Philadelphia hospitals or Temple in general going forward? Because they're now starting to do the program as well.
Yes, yes, we are. And there's a bunch of hospitals that are what you just said. They've done a few. They'll do a couple, and that's good.
I mean, I love Hopkins, and you guys are leading the charge. So
We're trying to
I
lead the
love
charge.
it.
We want others to do it as well, obviously. Sometimes I get calls from places that have done 2 or 3, and they're like, "Oh my God, it's a disaster." You know, we did somebody and they didn't do well, and that's what I worry about. Is I worry about a bunch of places doing one or you know, and because it takes work, it takes a protocol, it takes a staff, it takes an investment, it takes best practices on the back end. So I want it to be normalized, no question. And I want people to do it right. Do you get what I'm saying? I don't want people to start doing it, but do it wrong. And then they have a bad outcome and everybody goes, "Oh, I knew you shouldn't have done that." I always said that was a bad idea. If people are going to do it, they got to do it right, or else it's going to be a public relations problem. And it's going to be poor selection. So Temple is a great center. I'm glad you had a good result. And folks, get going. Sometimes they call, sometimes they just read this stuff. It's all published. You don't have to call me. It's all the protocols and practices and outcomes are all published. And the doctors up there can go online and have the whole experience on their computer. So it's exciting. It's exciting to see. I'm a little nervous. I want people to have good results too, but it's coming.
Thank you.
Sure. Thank you.
Anybody else?
Do you want to go to the chat
I'm going to
feature
mention
now,
a couple
Dr.
of
Cameron?
Sure. So a couple of people have already spoke up, but let me,
Right.
this one, study survival
Survival
rates
rates.
continued to abstain actually means they were still alive. So let me reiterate that the survival rate, just being alive after a year, is 94%. It's as high as any other indication in liver transplant, higher than some. The return to any alcohol is 20%. The return to harmful drinking is 10%. So let's 122 is a confusing number. Let's imagine we did 100 people. 94 of them are still breathing. 20 of them had a single glass. 10 of the 100 had dangerous drinking. Those are the numbers. So it's very high survival. In my opinion, it is, I don't know, low, but it's acceptable relapse. It certainly is acceptable given that it is comparable to other relapse rates, like after 6 months. Now, let me tell you another thing. If you get transplanted for hepatitis C, hepatitis B, Wilson's disease, anything, and we look at return to alcohol after those, it's 20% too. So there's nothing, it doesn't seem that this cohort is in any way problematically different from other cohorts that have a liver transplant. And that's why I don't think they should be automatically excluded. All right, we got Larry Hagman on Dallas here. So this is bringing up the question of unfairness. When a celebrity gets a transplant, is that good or is that bad? It brings public awareness to it, and is a help for donation, or is it a sign that there is unfairness, like what I referenced at the DMV? I know these organs go to rich people. Steve Jobs got a liver transplant. Is that good or bad? I don't know. I want Steve Jobs to do okay. In fact, but Steve Jobs lived in California. Steve Jobs got his liver transplant in Memphis, Tennessee. It's interesting. Wonder why that was. Didn't do anything wrong, but there's interesting. And then Steve Jobs did poorly after his liver transplant, to tell you the truth. And then people say, "Oh, well, there you go." another rich guy beat the system and, abused it. It's worrisome to me, very worrisome. And I'm very worried about public perception, because the public are the ones that we're dependent upon for organ donation, and they trust us, and we got to live up to that trust. So question well taken. How much alcohol is acceptable after liver transplant? Very hard question. The easy answer is none. That's the easy answer. I'm going to leave it at that. It's a hard question, but the easy answer is none. Are there only one transplant in May? No, these are only transplants. The dots are only alcohol use disorder related transplants. There are other transplants going on, but I just feature the ones that are related to alcohol. Blah, blah, blah. More, you better help others. It's the ones that go back to drinking. It's tough, but it's a tough disease. It's a disease like other diseases. It's very difficult. Alcohol. So that's a good point. So that's a very good point. That's a good one. So it's not only that we don't want you to drink after your transplant because you're going to mess up the new organ. If you are drinking, it's hard to come to clinic, and it's hard to take your medicines, and people vomit and aspirate. And there's a bunch of problems that happens when you drink alcohol, in addition to hurting your liver graft, as this question points out. Okay, that's a good one. Yep, very good. So good. This is what we just touched on. People that didn't get their transplant because of drinking. It's complicated, isn't it? Right? Like NASH, fatty liver disease. Are we out there telling people you ate too much, you don't deserve a transplant? And are we out there telling them I'm monitoring how much you eat after your transplant, because if you go back to overeating, I'm gonna get you? It's just different with alcohol. All these standards don't apply to other things. It's part of our society's complicated relationship with alcohol. And it really comes to a head with transplant. And I'm very sensitive to the fact that a lot of other disease conditions have behavioral related components. Very few don't, actually, to tell you the truth. Rewriting standards, they are actively aware and considering of it. Technically, they don't have to rewrite them. There isn't technically a rule against it on the books. Walter Payton did not get a liver transplant. He had cholangiocarcinoma. I don't know if that's true or not. That might be true. Cholangiocarcinoma is a very complicated indication for liver transplant. Still sober, love it. I love it. I love the good stories. I can have a million good stories. You know what? I have a million good stories, and I'm high. And then there's one bad one. And for some reason, the bad ones hurt exponentially more than the good ones help. You know what I mean? So it's heavy lifting, but I love the good ones. MELD scores used. These patients, so I showed you 88 patients, average MELD score 36. Okay, if your MELD score is not 36, we cross our fingers and hope you get better, and sometimes they do. This bending of the rules is for people that are going to die this weekend, and we have no choice but to do it or watch them die. So they're very high melders. Okay, UCSF, HIV, newborns. That's interesting. So there is a I don't know what, an uptick or a surge or a interesting phenomenon where little kids are getting acute hepatitis in the United States now. Some of them are going into liver failure and needing transplants. We're doing about 20 pediatric liver transplants a year at Johns Hopkins. Betsy King, if any of you guys have met her, is a new superstar taking over that program. We have not seen any kid with this acute hepatitis. It's not clear what it's from, to answer the question. Some people worry if it's COVID related. Some people worry it's adenovirus related. In adults with acute liver failure, the cause is often recognized. With little kids with acute liver failure, it's sometimes not ever figured out what caused their liver to fail. All right, that may be it. You guys had enough? Yeah, it's good.
We do have Dr. Cameron. I mean, you're fabulous. I mean, really, my husband's here because of you. So I can't tell you how much I appreciate your outlook on all of this, but there has been an iPhone user, no name, that has had their hand up. So if you're next in the car there.
Let's go.
Hi, good afternoon, team and guests. My name's Corey. I'm 9 months post-transplant. And listening to this information, I was driving and I wanted to participate in the meeting. I want to say thank you for sharing this important information, because this information will be valuable also for our families and caregivers and people that have health concerns, but don't even know what's available. I had no idea that Johns Hopkins, that's where I had my transplant, that we're like very rare. We're like the exception, 1%, 2%. I had no idea that this was so serious, and so, because it all happened so fast for me. So I just want to say thank you to you for presenting this, so I can go out into the community and talk to, and share information with people about what's possible, because like you said, there's a lot of distrust for different reasons. So I just want to say thanks.
You're welcome. You are welcome.
And then Nina has her hand up again. Nina, final comment?
No, that was a mistake. I'm viewing from my phone.
Oh, okay.
I agree with the previous person in that I think community dissemination of this information is going to be very important, because not everybody has access to journals from behind a paywall.
We're working on it. We appreciate you guys working on it. I totally appreciate you guys spending your morning with me. You know, we're here. We're open for business. Next time I see any of you guys in the halls, grab me, okay?
Yeah, and thanks for touching on that subject, AA. I know that's a touchy subject.
No, it's all good.
But
It's all
I'm
good.
not anonymous. I love the program.
Well, I love it too, actually. We all got to stick together. We all got to work together. None of this is perfect. We just keep pushing forward.
Thank you.
Thank you, Dr. Cameron. It was really excellent. And we're going to close out the meeting.
Dr. Cameron, I get to work with you every day on the floor at Hopkins, and I get to talk to a lot of those liver recipients. And I want you to know that none of us feel that we would be here if it wouldn't have been for the help of you and your team. I see the appreciation in their eyes every day and their second chances. And if it wasn't for your insight, a lot of people would not have had that second chance. I just want to say thank you.
Hey, Marty, you know, it's the best part of my day and their day every time we see you. That's a
You're
fact.
the best. You're the best
That's a
positive
fact.
guy. You are the best. So we thank you all for attending today. And we love seeing everyone.
And we want you to remember to check out our website, www.triomaryland.org. All our sessions are posted on the YouTube channel for those who are not aware of it. And we also have a great Facebook and a Twitter page, so please check us out and like us. And we really want to wish everyone a safe and healthy weekend. Thank you so much.
Thank you all. Thanks for participating.